Good evening, everybody, and welcome to this evening's webinar, Neurosurgery, Pituitary Tumours and Aneurysms. We are joined by our presenters this evening, Professor Antonio De Eva and Dr. Shinyo Liu, and our facilitator, Dr. Tim Senior. Before we jump in, I would like to make an acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past and present. I'd like to formally introduce our presenters now. Professor Antonio De Eva is a consultant neurosurgeon with 18 years of experience in brain, skull-based, peripheral nerve and spine surgery, as well as pain neuromodulation. He is a professor at Macquarie University, professor of neurosurgery in Italy, and associate professor of neuroanatomy in Austria, with main interest in neuro-oncology, traumatic brain injury and concussion, skull-based surgery, and pain neuromodulation. Professor De Eva is an Australian Research Council Future Fellow and Head of Computational Neurosurgery Lab at Macquarie University. Dr. Liu is a Fellow of the Royal Australasian College of Surgeons. He graduated from University of New South Wales Medicine with Honours and was trained at major Australasian neurosurgical centres, including Royal North Shore, Auckland City, St George, and Macquarie University Hospitals. During training, he completed an award-winning PhD and Master of Surgery at Macquarie University. His academic and clinical subspecialty interests include fluids of the CNS, neurovascular conditions, spine, and neuro-oncology. He has academic appointments at UNSW, UWS, Macquarie University, and University of Auckland. And finally, our facilitator this evening, Dr. Tim Senior. Tim is a GP at Tharawal Aboriginal Corporation in southwestern Sydney. He's also an RACGP medical advisor for the National Faculty of Aboriginal and Torres Strait Islander Health and senior lecturer in general practice and Indigenous health at UWS. So welcome, Antonio, Shinyo, and Tim. And I'm going to hand over to Tim now, who is going to take us through our learning outcomes before we hand over to Antonio this evening. So welcome, Tim.
Thank you very much, Sammy. Good evening to you all. I hope you're all keeping well, and those of you in lockdown are doing all right. These are our learning outcomes for this evening. So this is educational speak for what we're going to get out of the next hour or so. So that by the end of this online activity, we should be able to recognize radioanatomical features related to the diagnosis and treatment of tumours of the sellar and parasellar regions. Be aware of the different surgical options for the treatment of pituitary tumours and optimize patient surgical post-surgical management. Discuss the treatment options, risks of management and follow-up of both ruptured and unruptured aneurysms, and discuss some of the landmark evidence that informs contemporary management of aneurysms. So I'd like to introduce Professor Antonio to start us off. Thank you very much.
Thank you very much, Tim and Sam. So, should be able to see my screen now?
Yes, we can.
Sorry, it failed the first time. I don't know why.
That's all right.
So good evening, everyone. And I'm very glad to introduce the topic on the pituitary surgery, as my main interest is skull-based surgery. So we talk about the master gland. It has this definition because it's really astonishing to think how such a small gland in the center of the skull and the head can control so much the metabolism of the human body. If you remember that the anterior portion of the pituitary gland is called the adenohypophysis, and it produces 6 hormones, whilst the posterior part is the neurohypophysis, producing 2 hormones regulated by hypothalamus over here in the brain. And all these combination of hormones can control all the most important metabolic functions of the human body. The master gland has also a position of paramount importance in the brain. If you consider that is in the center of the skull base in a structure called the sella, and is surrounded by structures called cavernous sinuses, in which there is the carotid artery and some nerves which go to the eyeball, including the 3rd, 4th, and the 6th nerve for the movement of the eye, as well as the trigeminal nerve branches. And upwards above the pituitary gland, there is the optic chiasm. So it's very importantly related to the vision as well. And the more above, we have the brain, of course. Below the pituitary gland, we have the sphenoidal sinus, which is a very important gate to reach the pituitary gland, as you will see later on. So when we talk about pathologies of the pituitary gland, the most common one is the pituitary adenoma. It's pretty common if you think that the prevalence is 20% of the general population, and 77 cases every 100,000 people may have a pituitary adenoma. Generally defined so-called benign tumor, although I will explain that is not always the case. Not always they require treatment. In general, 50% they do, but many other times we just do radiological follow-up over time because they do not grow or they do not cause any troubles. They might be classified as a secreting if they secrete a hormone, or they are just giving a mass effect on the structures around because they do not secrete anything. And just for the size, they can define as a microadenoma when they are smaller than 1 centimeter, or macroadenoma when they are bigger than 10 millimeters. Or they can be even giant, like 3-4 centimeters in diameter. Pituitary adenoma is the commonest one, but there are many other tumors, because if you consider that this is the skull base and the pituitary gland is here, this is what we call parasellar region, and whatever can come around can affect the pituitary gland as well. So it can be meningioma, for example, coming from the meninges, or other tumors like schwannoma, craniopharyngioma, paraganglioma, and the other tumors that we'll see some examples later on. So you may understand that such a complexity requires also a complex team, and the pituitary team is formed by general practitioners, as well as many specialists, including endocrinologists, neurosurgeons, neuroradiologists, ENT surgeon, and so on. So you can well imagine that the GP is the central hub of a very complex network, and the multidisciplinary team meeting is a very important meeting that we do to have a better characterization of the lesion and to have a better agreement for an optimal decision-making for our patients. So the neurosurgeon, of course, has different functions in this team. It's not just the surgery itself, but is also examining the patients from the neurological point of view, and checking the images, checking the blood test, and assessing the indication for potential surgery. Endocrinologist is always involved, especially when the tumor is secreting. So there are some static tests to check the pituitary function, but also dynamic tests to see how these the pituitary function or dysfunction can be checked and ruled out. The endocrinologist is very important also when the tumor is not secreting, because of course the mass effect caused by the pituitary tumor can cause a compression on the normal pituitary gland. So instead of having a rise of the hormones, you can have a kind of a panhypopituitarism. Neuro-ophthalmologist is involved when we have a macroadenoma. For example, the tumor can compress the optic chiasm, and this is the typical bitemporal hemianopia, in which the patient has a loss of the visual field, especially in the temporal part of the visual field, and he has a restriction just to the nasal parts. Sometimes patients do not realize this kind of deficit because it comes very, very slowly over time, and they just start to tilt and turn the head more and more, and many times they compensate the deficit. And many times they come to do a visual field which is already as severe as this one. Moreover, the ophthalmologist checks also for the function of the cranial nerves moving the eyeball. So patients having diplopia can be affected in terms of compression or the third or sixth nerve, for example. And it's very important to have also the involvement of the radiologist with some expertise in neuroradiology. And the radiologist does not give us just some indication on the feature of the tumor itself, but also on the anatomical localization. So we have, this is an MRI of a macroadenoma, and you can see that it's very important to know if the tumor or which compartment are more involved by the tumor. So in this case, this tumor is compressing the optic chiasm and is invading the cavernous sinus on the right side, wrapping the carotid artery. And we have a different classification system to see how the tumor invades the compartment. The most important one is not just the Hardy classification system, which is purely diagnostic, but also the KNOSP classification system that is even prognostic. Why? Because the tumor can be characterized if it invades or not the cavernous sinus. And in general, we know that a grade 3 or grade 4 is a tumor wrapping the carotid artery and invading the cavernous sinus. And why is prognostic? because we know that this kind of tumor most likely will not be cured just by surgery, because of surgery we can remove very easily this part, but the part in the cavernous sinus is very risky because we risk with the carotid artery and the patient risk ophthalmoparesis with the diplopia. So many times this classification system gives already us the indication before the treatment that most likely this patient will need, for example, surgery and something else. And this is something else could be, for example, gamma knife radiosurgery, which is a very high dose of radiations collimated in one single spot, which is the tumor itself. And that's why it's as precise as a surgery, but it's a radiation treatment, basically. So when I define so-called benign tumors, this is an example that I'm bringing with me since many years, just because it's an example that the pituitary tumor is not always benign. Imagine this patient having a 3 operation for a Cushing syndrome, because this is an ACTH tumor. But after that, she was not cured and she underwent a resection of the adrenal glands. After that, she had a regrowing of the tumor, because this is called the Nelson syndrome, when there is a loss of the feedback. She underwent radiotherapy following after that. She had ophthalmoparesis. She was blind in one other eye. And at the end of the day, she underwent even a treatment which is the temozolomide that you may know that is used for glioblastoma. So this is a benign tumor treated like a cancer. And eventually the patient even died after the 9 years for complications related to the secretion of the ACTH and the cortisol. So it's not always a benign tumor. And this is something that we defined and classified in a paper published 7 years ago in Nature Review Endocrinology, in which for the first time we're talking about aggressive pituitary adenomas, which behave almost like cancer. So these are something which has to be estimated in a better way. In terms of treatment, we can treat surgery, we can go to the pituitary gland by means of a transcranial approach or endoscopic transsphenoidal approaches, or combination of these approaches in what we call cranioendoscopic approaches. Nowadays, a great part of the operations are performed endonasally and with an endoscope, so with the help of the ENT surgeon. And you can well understand that this looks minimally invasive because we enter in the nostril, which is an anatomical pathway, reaching the sphenoidal sinus, which is our gateway, not just for the pituitary gland, but for the entire skull base, from the crista galli all the way to the clivus. And so basically we can treat all the midline lesion of the skull base by means of extended approach in the sphenoidal sinus. So here we go with some illustrative cases that I have collected over the last year, just to show some examples. This 34-year-old gentleman had a headache and a visual deficit. It's interesting that when presented to me, had underwent a transsphenoidal resection of a 3 centimeters tumor, which was a gonadotrope type. Now, after 1 year, he had a headache again, and they spoke about the growth of the tumor. So imagine that the tumor with the maximal size of 3 centimeters grew to 2.8 centimeters. So the take-home message for this specific case is that the pituitary adenoma are very, very slow to grow. It's very rare that the tumor can have such a big growth. So many times there is a bad definition of a cure of the adenoma when the tumor was just biopsied rather than resected. Indeed, when I saw this patient, this was the big adenoma. But if you go to see the CT scan in a bone setting, you can see that this is the window that the first surgeon did. So basically means that from here, it was impossible to remove all this tumor. So eventually it was just a very partial resection. And then what was called a recurrence was not recurrence, was a remnant. And the remnant underwent a total resection, which is shown here. So this is the operation I did, in which it showed the scar of the previous operation. This is the tumor, all the tumor exposed, and the tumor at the end of the resection, in which it's possible to show the normal anatomical landmarks of the sella. So in this case, it was a total resection. And so the take-home message for this slide is the big difference between recurrence, which is a real something recurring over time, or a remnant, which is something left over from the previous treatment. Acromegaly is pretty rare, but it's important that the GP recognize this, because many times these patients come to attention of endocrinologists and neurosurgeons really very, very late. Imagine this patient with diabetes, hypertension, and sleep apnea, which are all features of acromegaly. But the most important thing that was not considered by the patient and carers is that his hands were growing over time, and even his tongue was growing over time. When they did the test of a GH growth hormone, it was very, very high. But look, for example, his hand. His hand was completely considered growing over time very slowly, but this is a student of mine putting her hand in comparison of the patient's hand, which is huge. And even the patient was changing the glove size basically every 2-3 years. And this is the tumor, which was an acromegalic tumor, AGH-OMA, which can be completely cured by the surgical resection without using any treatment or any other treatment. And indeed, after a total resection, you can see that very, very quickly the growth hormone falls down, and over time, the hormone which is triggered by the growth hormone, which is the IGF, insulin growth factor produced by the liver, over time also normalizes. So this patient starts to have a better control of all the problems related to acromegaly. Cushing disease sometimes is pretty bad already when the tumor is very small, like a microadenoma. This patient had hypertension and borderline glucose intolerance with acne, hirsutism, headaches, proximal muscle weakness, and central obesity, which are all features related to high level of cortisol in the blood, including the dorsal fat pad. So she had a Cushingoid with the face with the moon fascias and the stria on the belly. This is the typical resection we do, and you can see that this is the normal gland, and the tumor here is very, very small. It's just 5 millimeters in diameter. But when the tumor is removed from this location, the patient can have a normalization of the cortisol very, very, very quickly, and so can be considered cured. So this is the whole at the end of the 5 millimeters resection of the microadenoma. Apoplexy is one of the few emergencies we have with the pituitary tumors. Means that an adenoma is very, very indolent many times, but when it bleeds, can give a mass effect very important on the gland, so causing a pituitary panhypopituitarism and the compression of the optic chiasm. This patient, for example, already had multiple episodes of apoplexy. But one of those brought the patient to the emergency because she felt very, very sick. And that's what we saw, a huge bleeding in the cavity of a previous resection. And this is the typical the typical surgery, in which basically you can see that we don't remove that much of tumor. This is the only tumor, but basically this is more blood. So it's really fresh blood or subacute bleeding in the cavity, which is giving rise to a compression of the surrounding structures. So this is one of the few emergencies we have in pituitary surgery. And the postoperative imaging showed a complete resolution of the bleeding and no mass effect on the gland or on the pituitary, on the optic chiasm. Completely different lesion, but a very similar feature is the Rathke cyst. The cyst. This is just a cyst. So basically, it's a lining of epithelium, which is filled with with a kind of a liquid which looks like cerebrospinal fluid on MRI. And the patient can come even blind. This patient came with a very bad bitemporal hemianopia. And if you see the lesion, it looks like a huge tumor, but this is just a lesion which is a cystic, which an intensity on T2 which looks like the cerebrospinal fluid, and the T1 looks again CSF. So this is not really this is not an adenoma. And what we do is trying to remove the capsule, but this is not the most important thing. The most important thing is reducing the mass effect. So many times we just create a hole in the lesion itself, an operation that we call marsupialization. So basically we create multiple holes in order to drain the liquid out and to reduce the mass effect. So this is the capsule which has been sent to the pathologist and it came back like normal lining of a cyst, and is just creating multiple holes. And as you can see from the postoperative MRI, there is no mass effect anymore because the cyst is completely gone. And she recovered the vision very, very quickly, a few days after surgery. Completely different lesion is a meningioma. As I told you, there are sellar and parasellar regions tumor, completely different regions from adenoma. And this is historically tumor just treated by means of a transcranial approach. But nowadays we can do very selective choices in our approach, in which this is a meningioma coming from a structure called the tuberculum cell in the skull base. And you can well see that the easiest way is going from the nose in the sphenoidal sinus to remove this tumor. So this is the neuronavigation system bringing us to where we have to be. This is the tumor. This is the histopathology showing clearly the feature of a meningioma. And this is the surgery in which it's shown that we can go in an extended fashion upwards to remove the tumor, exposing the brain, exposing the arteries of the circle of Willis, exposing the optic nerves with a very, very small cut inside the dura, which is less than 2 centimeters. But everything is done from the nose. Craniopharyngioma is a completely different lesion, is very rare, is a remnant of an embryological structures. Is rare, but can give a lot of troubles because many times they can give a completely panhypopituitarism, diabetes insipidus, and compression of the optic structures. So a patient that can show up with hemianopia or even blind sometimes. There are essentially 2 different kinds. One is a mainly cystic. So this is a cystic craniopharyngioma, and you can see from the surgery that we are talking about a cyst. So this is a lining. The difference with the erratic cyst is that erratic cyst we don't have to remove in the lining. In this case, we try to remove as much as possible because otherwise we can have a recurrence. And by removing this cyst, you can see the normal structure. This is the pituitary stalk there. So the infundibulum, this is the frontal lobe of the brain, and the pituitary gland is here. So this is above the pituitary gland. And it's a very complex surgery just because we try to preserve all the structures around. Because, for example, look here, there are very, very tiny arteries like this, and we cannot close these arteries because these are terminal arteries going to the optic chiasm. So they're called the superior hypophyseal artery, but if we close this, the patient can get a blindness, basically. So every structure has to be preserved, including here the anterior cerebral artery, the brain, and etc. So it's still a benign tumor, but it can give rise to a lot of problems. And look here, the optic nerve, how smooth and thin is because compressed by the tumor for many, many years. The craniopharyngioma can be also very solid, not cystic, and this is a subtype called papillary. This is an interesting case I did over the last few months. It was a very solid tumor compressing the optic tracts, not the optic nerves, and the patient was almost blind, one eye. And in this case, for some reasons, that's too long to explain, but basically I decided to do a transcranial approach to try to remove as much tumor as possible to decompress the optic tract. And the goal was achieved because the tumor, although I did just a subtotal resection, the patient recovered the vision. The problem is that 6 months later, he got a tumor which was a double size of what I already removed before. This was a real recurrence, which is pretty rare for a craniopharyngioma. But to make the story short, this is the tumor going even inside the 3rd ventricle. So in this case, I decided to do an endoscopic transsphenoidal approach. And in this case, we were able to achieve a total resection, also because the patient had already a complete dysfunction of the pituitary gland. So in this case, we could be a little bit more aggressive because there was not so much to lose anymore in terms of preservation of the pituitary stalk. And we could attempt a total resection in order to decompress the optic nerves. And indeed, after the total resection, this is the last remnant of the tumor that here is shown that I'm cutting from the optic tract. This is the optic tract, and this is the last piece of the tumor left over. And as you may remember from the MRI, the tumor was even going in the 3rd ventricle. And indeed, this is the endoscope put from the nose in the 3rd ventricle. So you can even do intraventricular surgery from the nose. And the fact that you can see the ventricle here shows that the ventricle is unplugged. So the tumor is completely out. And this is such a nice picture that I will show you again, because it's not very common to see the 3rd ventricle from endoscopic approach. These are the foramina of Moro, which bring to the lateral ventricles. This is the fornix. This is the hypothalamus here. And these are all the structures which were plugged by the tumor before surgery. And this is the MRI after surgery, which showed complete resection and optic chiasm completely free. Last tumor is a chordoma. It's the last tumor that I want to show that is also very rare. It's 1 every 1 million people. And we're talking about benign tumors giving a lot of troubles. Chordoma is locally aggressive, so this is less benign than the other one we've seen before. It's very difficult to remove, and many times surgery is not definitive. Many times people they have to undergo radiation therapy or even something much more aggressive like proton beam radiosurgery for the country which have that kind of a modality. So this is a young girl that I did years ago coming with headache and double vision. And this is a tumor coming from the clivus, destroying, eroding the clivus, so very aggressive tumor. And we did almost total resection, leaving something small. This very, very small thing grew after a few years. And this is a patient that I did when I was in Toronto, for example, and the patient went to Boston to do proton beam radiosurgery later on. So it's a very complex pathology to treat. Last but not least, whatever the treatment is very important, also the post-operative management. And if you remember the involvement of the team, how important having different disciplines in the pre-operative assessment, and intraoperatively also we need more disciplines like a neurosurgeon and the ENT surgeon, for example. In the post-operative assessment is the same. So radiologist is very important. We need to understand if there is a remnant or recurrence or the complications related to the surgery. The neuro-ophthalmologist is very important to check the visual field, if they're getting better, worse, or not. The ENT surgeon is involved to check the nose because there are potential nasal complications following the surgery. And according to the histopathology, we might have the involvement of other specialists like the neuro-oncologist. You have seen the involvement of the neuro-oncologist in the aggressive pituitary adenoma before, in which we had to use a temozolomide, for example. And sometimes the radiation oncologist, because the patient might need gamma knife radiosurgery or fractionated radiotherapy, like the tumors I showed you before.
Other medications which shrink pituitary tumors, and a specific question about whether we can start cabergoline before, as a GP, before referring.
Yeah, thank you for focusing on that. I was so focused on the surgery that most likely I missed the one thing, that all the tumors but the prolactinoma are surgical. But for example, the prolactinoma is the one that in general can be managed very, very well with the Dostinex, cabergoline, and these tumors shrink very, very quickly. Remember two things: a tumor can shrink, but it can still bleed, so can still need surgery, and the 30% of the prolactinoma can be resistant to the dopamine agonist. So 30% of prolactinoma are still surgical. Moreover, there are other kind of tumors, like even GHoma or actioma, in which the medical treatment is still there, but is not the first line. So prolactinoma, medical treatment is the first line. All the other tumors, surgery is the first line. Last but not least, there are also patients that they shrink the tumor thanks to prolactin, but they have to keep going forever. And as soon as they stop, the tumor comes back. And some patients, they want surgery in that case because they start to have side effects or intolerance to the cabergoline, for example.
Lovely. Thank you very much.
Thanks to you, Tim.
All right. Good evening, everyone. My name is Shanu, and thank you for participating and staying awake. I know everyone would much rather be watching Netflix with their children and dogs. But aneurysms are pretty common, and I get a lot of questions about aneurysms. So hopefully tonight we can take away a couple of key messages that will allay fears of patients, address really common questions. And I hope at the end of this talk, you can really be able to chat to patients about unruptured aneurysms, maybe even a little bit about ruptured aneurysms and subarachnoid hemorrhage, because they're becoming really, really common questions in the community. So the title of the talk is Bring the Thunder. For those of you who are fans of the hit Broadway musical Hamilton, you'll get the reference. But of course, the other thing that it refers to is the thunderclap headache associated with aneurysmal subarachnoid hemorrhage. So let's get into it. What's an aneurysm? Oh. Looks like the screen's not progressing.
Do you want to try putting it back in presentation mode and perhaps give spacebar or your right arrow on your keyboard a go. That's a bit strange that it's not progressing.
Very strange.
That's all right.
Sorry, everyone.
We'll give it a go. Zoom likes to keep us on our toes.
Oh, well, maybe I'll just have to do that. How's that?
Let's try putting it up again. We should be able to progress it. In your bottom left corner, there was little arrows that popped up, grey ones, but you can always right click on the slide. Oh, that looks like it's moving between those two.
All right, little hiccup. So yeah, so what's an aneurysm? An aneurysm is an abnormal dilatation of a cerebral vessel, okay? So of an artery. So the talk is not about, you know, aneurysms outside of the skull, okay? So the cerebral aneurysms are a very different beast, and we'll come to that in a bit. But to get to the definition, an aneurysm is usually forms on a branch point, and it's important to understand that they involve abnormalities that encompass all three layers of the artery. So that's the intima, the media, and the adventitia. And a classic, you know, textbook, you know, description of the abnormality at the microscopic level is that there's a breakdown of the internal elastic lamina. And we think that the reason why aneurysms happen at branch points is because of the hemodynamic stress that occurs when the blood has to, you know, flow around the branch point, and that leads to shear stress and energy loss. So it's probably a mixture of hemodynamics and some kind of inflammatory reaction that involves a whole variety of, you know, inflammatory agents like TNF and interleukins and MMPs, metallo matrix proteinases. So the reason why aneurysms in the brain are different compared with aneurysms in the abdominal aorta is because aneurysms in the brain lie in the subarachnoid space. Okay, that's a very different environment compared to the retroperitoneum. And so the other important thing is that the adventitia of the artery is quite different. It's very deficient compared to, say, a thoracic aorta aneurysm or a renal artery aneurysm. And so this probably explains why there's a fairly high frequency of these aneurysms in the general population, which we'll again get to in a moment. So this is a dissected specimen from a patient who's passed away of something else, but you can see an abnormal dilatation of this, you know, on this this bifurcation of the internal carotid artery into the middle cerebral and the anterior cerebral arteries. That's a fairly common location. So cerebral aneurysms found in the subarachnoid space, and that's what makes it dangerous, because if the aneurysm ruptures, then blood is spilled all into the subarachnoid space, and this is one of the most devastating causes of strokes in our community. Aneurysms are found in the anterior circulation at least 85% of the time. So that means the internal carotid artery and its branches. So very common locations include the anterior communicating artery, the middle cerebral artery bifurcation, the posterior communicating artery, and about 15% of aneurysms are found in the basilar apex, or the bifurcation of the basilar artery, and the posterior inferior cerebellar arteries. Okay, there are other locations, but they're not that common. So far we've been talking about saccular aneurysms or berry aneurysms, you know, they're commonly referred to, and they comprise at least 90 to 95% of all, you know, cerebral aneurysms. There are other types of aneurysms. So if you look at this diagram here, this is a bullet. So this poor person has a bullet lodged in, near the interhemispheric fissure between the two halves of the brain. And a delayed cerebral angiogram shows that there is a little aneurysm, okay, at a very unusual spot. And so this is what we call a traumatic aneurysm. And they're different from saccular aneurysms because they often don't involve abnormalities of all three layers of the artery. So they can, be a complete blowout of an artery, and the only thing covering, the little blowout is a clot or a really thin layer of adventitia, and so they're highly, highly dangerous. But of course, they're very uncommon because we don't really have very many gunshot wounds in this country. This is an example of what we call a giant aneurysm. So giant aneurysms are really quite uncommon. They comprise less than 5% of all saccular aneurysms. And they're defined as anything bigger than the inch. Okay, so 2.5 centimeters. This series of diagrams demonstrates what we call a blister aneurysm. So they're often found on the internal carotid artery. So a blister aneurysm is often due to a dissection. So so hematoma gets in between the intima and the media, or the tunica media and the adventitia. And again, you get this really unstable blowout in the entire wall of the artery. And the only thing that might be covering the wall of the artery might be some thin adventitia or maybe a blood clot. And so they're very treacherous lesions. And then finally, we have this very unusual aneurysm that's found on a very distal branch of the anterior cerebral artery. And so this is in a patient with infective endocarditis. So very similar to, say, a traumatic aneurysm. You get little septic emboli that travel all the way to the distal branches, and that causes an inflammation in the wall of the artery. And again, you can have a highly unstable wall morphology. You might only have one or two layers covering, a defect, instead of all three layers in a saccular aneurysm. Right, so how do aneurysms present? More and more we're seeing aneurysms found incidentally. So a patient will have headaches, or they have tinnitus, or some kind of dizziness, and they get a scan. And then because MRI scans and CT scans are becoming A, more prevalent, and B, more sophisticated, we can see even, 3 or 4 millimeter aneurysms. And so that's by far the most common way aneurysms are presenting these days, at least in Sydney. People have a scan for another reason. Aneurysms generally don't cause symptoms, okay? They're found in the subarachnoid space. They keep enlarging, and the first time that many aneurysms present is when they rupture. So that's with a subarachnoid hemorrhage. You'll recall that the aneurysm arises in the subarachnoid space. So blood is spilled in the spaces that contain CSF. And so this is an example of a patient with a very classic aneurysm arising from the anterior communicating artery. I know this because this is what we call a flame hemorrhage in the frontal lobe. The patient has this characteristic high density, okay, this white stuff that looks like a spider pattern. And so that blood is spilled all over the basal cisterns, okay? And hydrocephalus as a result of subarachnoid hemorrhage is very common, and this patient certainly has it. So subarachnoid hemorrhage, probably the second most common presentation. But there are other ways aneurysms can present. So a posterior communicating artery aneurysm is very close to the oculomotor nerve. And you can see that this is the internal carotid artery with an abnormal dilatation. So that's the aneurysm. And this here is the oculomotor nerve. So the oculomotor nerve has the the autonomic fibers, so the parasympathetic fibers that cause, dilatation of the pupil on the outside. And so an aneurysm, when it enlarges, it compresses all the fibers, both the parasympathetic stuff on the outside as well as the motor fibers. And so you get a complete third nerve palsy. So the patient presents with complete ptosis, so the eyelids shut, the eye is down and out, and the pupils don't work. In diabetes, however, you get this microvascular, ischemia, all right? So that affects the motor fibers, okay, in the middle. But the peripheral fibers, where the parasympathetic fibers run, are spared. And so in diabetes, you can actually get a third nerve palsy, but the pupil still works. So this is what we call a pupil sparing, deficit. And so when a patient has both diabetes and a posterior communicating artery aneurysm, often you have to just rely on the examination of the pupil to figure out what's going on. Aneurysms can cause strokes, ischemic strokes, if they're large, okay, and they have thrombus within them. So this is an aneurysm in the internal carotid artery near the skull base. And this is an example of an embolic stroke, where clot within the aneurysm has been thrown off. And you get this distal MCA infarct. And so this is an MR angiogram showing this medially projecting aneurysm, which is incompletely imaged because part of this is all thrombus. You can't see it. And this catheter angiogram also does not show it. So aneurysms can rarely cause embolic strokes, okay? Right, so this is a really important slide. Aneurysm, there are some pretty cool, important statistics that I think will allay a lot of patients' fears. Brain aneurysms are really common. We think they affect 2 to 3% of the general population. And yet subarachnoid hemorrhage, so aneurysmal subarachnoid hemorrhage, only occurs 10 out of 100,000 people every year. So in New South Wales, that's only 800 people compared to 3% of 8 million people. I mentioned that if you get a subarachnoid hemorrhage, that's 5% of all strokes in our community. And if you do some fancy mathematics, we think that something like maybe 0.5% or 0.25% of all aneurysms rupture during a patient's lifetime. So perhaps something like 99% of brain aneurysms will never ever rupture, okay? Aneurysms generally get diagnosed or present with a subarachnoid hemorrhage between patients in the 40s and 60s, and they peak during the 50s. Women get aneurysms more than men generally after menopause, which is in the peak incident period. But before menopause, men and women are affected equally. We think something like 10% of people die in the peri-hospital period, which is very significant. And of those people who make it to a hospital, something like 2/3 of patients will end up with some kind of neurological deficit. So it's a really, really big problem for those 800 people in New South Wales who get an aneurysmal subarachnoid hemorrhage every single year. So if 99% of aneurysms probably don't rupture during a patient's lifetime, and most aneurysms are diagnosed incidentally, when a patient has an MRI because they got hit on the head with a cricket ball, and here they are with an MRI brain with an MCA aneurysm, how do you decide whether the patient needs prophylactic treatment of the aneurysm? How do you counsel a patient as to whether this aneurysm is so-called safe or so-called dangerous? So we look at two sets of factors. There are aneurysm-specific factors that the patient has no control over, and then there are patient factors, and some of these are modifiable. So we think that smoking and high blood pressure, and of course other cardiovascular risk factors are are strong contributors to aneurysm growth and rupture. So it's probably those pro-inflammatory cytokines and cascade to do with smoking that causes this. And then with high blood pressure, the more hemodynamically volatile the flow, the more stress is placed on the artery, the more likely you're going to form an aneurysm. There's nothing you can do about short stature or bicuspid aortic valves, but these are some of the patient factors that are thought to be associated with formation of aneurysms. And then the aneurysm size is important to determine whether it's going to stay the same and can be monitored, or whether we should be treated. We think that larger aneurysms are more likely to rupture. Some aneurysms, in the midline or have specific bifurcation points. So for example, the anterior communicating artery or the basilar aneurysm, because they're in the posterior circulation, are more likely to rupture. It's controversial whether multiple aneurysms are more likely to rupture. And then there are some other factors to do with, the morphology of the aneurysm. Is it smooth, or is it, bumpy? And, we think it's, suggestive of hemodynamic instability within the fundus of the aneurysm. So we take all of these into account, and we are able to kind of counsel the patient on the natural history of aneurysms. But that's a pretty large talk, so we might save that for another day. Are there aneurysms that are inherently safe? And the answer is yes and no. But generally, if an aneurysm is outside of the dura, they cannot cause a subarachnoid hemorrhage. So this is a diagram of the internal carotid artery as it courses through the base of the skull, and it has to puncture through 2 layers of dura, okay? And the 2 layers of dura form these dural rings, okay? A distal and a proximal one. And so any aneurysm that is formed proximal to the distal dural ring is not really, it's not really possible for these aneurysms to rupture and cause a subarachnoid hemorrhage. That's not to say they can't cause problems. So if you have an aneurysm in the cavernous sinus, okay, so the cavernous segment of the internal carotid artery, they can enlarge and cause cranial nerve deficits, or they can rupture and cause a carotid cavernous fistula. And these fistula means can mean that you have really high flow of blood from the artery into the cavernous sinus, which is venous. And patients present with chemosis and proptosis, so they have an angry red eye, and it's pulsatile. So this is a demonstration of the pulsatile, proptosed eye, and this is a cavernous sinus aneurysm. We might skip over this, but this sometimes aneurysms which you think might be outside of the dura will actually surprise us, and they're actually found just on the diaphragma cellar. It's actually intradural, so you have to sometimes get fancy MRI scans to determine whether they're intradural or extradural. So how do we diagnose aneurysms? Well, the gold standard is with a catheter angiogram. So it's basically a coronary angiogram, but you keep going higher and higher, and you get to and you do internal carotid and vertebral artery injections. And so that's the best test for it. But these days, CT circle of Willis angiograms are getting better and better, and their sensitivity, and specificity are in the orders of the high 90s. So they're very, very good for screening and diagnosis. MR angiograms are getting better every year, so they're not as good as CT angiograms, but in some institutions like the SAN, for example, they do excellent MR angiograms. And that's an example of an MR angiogram showing an MCA artery bifurcation aneurysm, okay, which is kind of fuzzy, and you think, oh, maybe there's an aneurysm there. And this is a CT angiogram of exactly the same patient and the aneurysm. You can see that you've got a little branch coming off the neck of the aneurysm. And so CTAs are very, very good. And of course, a catheter angiogram gives you the best pictures, and you can get reconstructions of the catheter angiograms. Right, so really briefly, if a patient has a thunderclap headache, all right, they really should be sent to the emergency department. And in the emergency department, a CT scan is performed. But if the CT scan is equivocal, so you can't really see subarachnoid hemorrhage, but the history is very suggestive of an aneurysmal subarachnoid hemorrhage, so a worse of a headache, came on like a thunderclap, the lumbar puncture still remains the gold standard, okay? And the emergency physicians will do a lumbar puncture and send the CSF for bilirubin and oxyhemoglobin analysis. And so this is what we refer to as xanthochromia. Family screening is a really common question. So to summarize, there really aren't international guidelines on who should get screened, but we generally recommend that if 2 first-degree relatives have aneurysms, then all the first-degree relatives should be screened with an MR angiogram or a CT angiogram after the age of 18. Children do harbour aneurysms, but it's exceedingly rare as hen's teeth. And if families have, if there are multiple family members with aneurysms, maybe they have a predilection for forming aneurysms. And so it's a good idea to do screening every 5 years with a CT or an MR angiogram. So briefly, how do we treat aneurysms? So aneurysms can be treated from the outside. So that's with open clipping of the aneurysm with an aneurysm clip to reconstruct the artery, or they can be treated from within the artery with coils, with stents that ensure that the coil can be packed in tightly, or with special flow diverter stents, okay, which allow blood to flow through the blood vessel but not into the aneurysm, and so over time this will form a thrombus. So neurosurgeons do this, interventional neuroradiologists and some dual-trained neurosurgeons do these ones. So what do we do as neurosurgeons? Most aneurysms are in the anterior circulation, so they're often in, say, the middle cerebral artery. And so this is an example of a craniotomy, an open craniotomy, called a pterional craniotomy, because the bone flap is centered on the pterion. And so given a general anesthetic, the head is placed in in rigid fixation. And I didn't do this, but some neurosurgeons like giving funny haircuts. We do much more minimally invasive haircuts. This is an example of an aneurysm clipping. So this patient has an elective repair of an aneurysm. This is the pterional craniotomy. That's the frontal lobe. That's the temporal lobe. So we're just opening the sylvian fissure. So we do not transgress brain. We don't operate in the brain. It's all outside of the brain. So these are middle cerebral artery branches, okay, which we skeletonize, and we divide the arachnoid, okay, and we follow the blood vessels from the really distal branches proximally to where the aneurysm is found. So here we are getting the aneurysm dissected, okay, finding the proximal middle cerebral artery, and here's the aneurysm, abnormal dilation, and we carefully dissect all the branches off the aneurysm dome. And then we place an aneurysm clip just across the neck of the aneurysm, nice and easy. We reconstruct the bifurcation of the middle cerebral artery, and then we go, let's just reinforce the aneurysm, and then we puncture the aneurysm and no more blood has come out. So that's how we fix the aneurysm. So, sorry about that. All right. So a brief, we probably won't talk about endovascular, but basically, you know, there are ways to determine how tightly packed the coils are. So there are a few large studies on aneurysms. So they include the ISUA, which is in the reference. So basically, big multi-centered randomized trials were conducted on cerebral aneurysms about 15 to 20 years ago. And the takeaway message is that many small aneurysms don't rupture. And so these give you the risk of rupture of aneurysms of certain sizes over 5 years. And so you really have to kind of get to the 7 to 12 millimeters to get to the 2 to 3, 2 to 15%, risk over 5 years of rupture, which is considerable. ISAT is a trial comparing open surgery to endovascular treatment in ruptured aneurysms. And so the take-home message is that both are pretty good, but endovascular surgery probably gives slightly more people, good neurological outcomes over 10 years, not by much. And so that's really changed the landscape of treatment of aneurysms. Far more coiling, far fewer open repairs. And then there are tools available for us to, calculate the risk of an aneurysm rupturing, in the next 5 years. They have problems, but they exist. And so in the community, when patients are discharged after a subarachnoid hemorrhage, or even sometimes elective aneurysm treatment, what do we have to look out for? So hydrocephalus, insidious. It's an insidious thing. It happens in 20% of people with ruptured aneurysms, and you really have to look out for it. When patients have aneurysm, have hydrocephalus, they really have to have treatment for that. So that's in the form of VP shunts. Patients can get Terson syndrome. So these are hemorrhages in the posterior compartment of the eye. So this shows a subhyaloid hemorrhage. And so you really have to look out for this. Ask patients, can they see properly? Refer them to ophthalmologists. And then when aneurysms get treated, sometimes they can recur. And so this becomes a chronic disease. So you can see how this basilar aneurysm has been coiled, and then you get recurrences over time. And this is a plug for Macquarie Neurosurgery, but we also, in the field of neurovascular neurosurgery, we also work in a multidisciplinary team. Patients often want to resume driving, and so we have occupational therapists who we can refer to for driving assessments. 60% of patients have neurological sequelae, so they have to. We sometimes send them to neuropsychology. Patients might have seizures, for a long time, and so we liaise with the neurologists, and of course our interventional neuroradiology colleagues. We meet with them every single week, and we discuss cases and what is the best management for our patients. And so that's it. Thank you very much.
Thank you very much. That was fantastic. We're finishing just on time. Thank you, everyone, for all your questions coming through as well, and thanks to Professor Antonio and Dr. Leary for answering those as we go. So these are our learning outcomes that we covered at the beginning. So hopefully, if you look through that, we've covered all of those this evening. I'd like to thank both our presenters tonight for covering so comprehensively such an interesting topic for us GPs, and thank you, Sammy, for organising us all behind the scenes.